hypoxia, hyperglycemia, fever, convulsions, etc. When you get a patient with stroke, you need to do a CT scan. And if you do a CT scan, remember that in the first 3 to 4 hours, a CT scan in acute ischemic stroke got to be normal. And therefore, that is important when we talk about lysis. What we do is, we do a CT scan, but within 4 hours, you might already start seeing some blurring of the gray-white matter, and you might see sulcal effacement. So that's a bit late when we are talking of lysis. Whereas on the 4th day, you can actually see this big mass here with mass effect. So, do we have an MRI to help us in the early stages? Yes, the MRI can pick up an acute ischemic stroke much earlier than a CT scan. And what happens is you do a diffusion weighted image, you do a perfusion weighted image. I'm not a specialist here, so I would only read out what is written there. I don't understand this so well. But basically what you have is a diffusion, perfusion mismatch in the first 1 to 2 hours. And that's where you can pick up a stroke initially with an MRI. But mind you, an MRI may be very specific, may be very sensitive test to diagnose acute ischemic stroke early. But on the other hand, it is not easily available at most centers. I think everyone in the audience would agree that. It needs expert opinion for interpretation, and it is extremely costly. And hence I would not advocate that it should be a mandatory universal investigation in the management of acute ischemic stroke, especially when you are thinking of lysis and you just do a CT scan normal with the correct technique, with the correct exclusion, then you should lyse this patient. So how do I manage a patient with acute ischemic stroke? There are 4 ways of doing it. One is the 8 Ds of management, which the AHA tells us. Then we talk about thrombolysis, then we talk about BP management, and we talk about secondary prevention. And I will talk in the next 5 or 10 minutes mainly on the second and the third criteria. What are the 8 Ds? From the time of detecting a stroke to dispatching the patient to a hospital, to the delivery of the EMS system, to the door of the casualty or the emergency room, data retrieved of the patient, etc., his condition when the stroke happened, or a CT scan taken, a decision then taken for lysis, whether after ruling out problems, and then D is the drug, which is you have given the drug, and finally the disposition, where the stroke unit and the critical care will set in later. So if you follow these 8 Ds from the time a patient has a stroke, you will actually do very well from detection till disposition and sending the patient home. How do you, clinically, a patient next to you complains of some weird behavior, how will you know that this patient has stroke or not? So you do a Cincinnati pre-hospital stroke scale, which is one of these 3 should be present. One is a facial droop, second is an arm drift. So you ask him to close the eyes and put his arms like this. If one hand goes down, that is positive, and or he will have an abnormal speech. In America, they ask this sentence, you can't teach an old dog new tricks. Please don't convert this into Gujarati and say, Kutrane, Navu, so whatever. So use something which is local, but it is important for us to know that whether he's got slurred speech or not. And any one positive increases your chance of stroke in detection of stroke by 72% at the bedside. So easy. Once you've done that, you need to obviously rule out hypoglycemia, you need to rule out seizures. Otherwise, somebody who's alcoholic and has had a seizure and is in post-ictal, and you lyse this patient and say, wow, I saved him. Arey, you could have saved him with a 50% dextrose, which costs only 10 rupees. Monitor the blood pressure, monitor the saturation, because I again keep mentioning, if there is hypotension in a stroke patient, there is increase by 50% in mortality. If there is hypoxia in a stroke patient, the mortality increases by 25%. So if you allow a patient to be hypotensive and hypoxic, he is going to have a 75% mortality. So these are the basic things you must do when you tackle stroke. You must give them oxygen, but not every patient unless the saturations are less than 94, and do a Cincinnati to identify. So you have to find out that this patient has stroke. You have to avoid hypotension and hypoxia. You give him oxygen, monitor his BP, and you rule out hypoglycemia and seizures, because those are the reversible causes, and we are not talking about lysing these patients. So always look at the airway breathing circulation, the vitals, send relevant bloods for investigations, and do a CT scan and read the CT scan. Not necessarily you have to read it, but it's got to be read. You now take a decision on lysis, and for the decision on lysis, you need to know that the window period for lysis in stroke is 3 hours. Now people have found such good results that they have extended this window period from 3 to 4.5 hours. But after 4.5 hours, if you lyse the patient, you have more chances of bleeding and less benefit. And therefore, the max you can stretch is up to 4.5 hours. Obviously, rule out the blood pressure, because a high BP, higher the chances of lysis causing bleeds. BP assessment should be done every 15 minutes, and less than 5% chance of bleeding happens if you lyse the correct group of patients. So relatives may ask you, if you lyse, what is the chances of him bleeding to death? Yes, he will bleed to death 5%, but if you don't lyse, he will be having morbidity and mortality much higher. There is a time frame for stroke, like you have a time frame for MI. In acute STEMI, you would need to lyse within 30 minutes. Here you need to lyse within 3 to 4.5 hours. But there is a door to doctor time of 10 minutes. You need to get a neurologist within 15 minutes. You need a door to CT scan. Once the patient comes to your unit, you need to get a CT scan in 25 minutes. And then 20 minutes are allowed for the radiologist to have fun, because he can read the CT scan after 20 minutes of doing it. Can anyone tell me why is that so? Because radiology is not an emergency? No, the reason is that now the definition for transient ischemic attack is different. The patient may have had a TIA, and within about 45 minutes to 1 hour, the TIA will move off. So you still interpret it at 25 minutes, but you wait till 45 minutes. Door to treatment would be 60 minutes, and admission to stroke unit would be 3 hours. We all know the contraindications for fibrinolysis, which are the same as an ASMI, but we need to understand the systolic blood pressure more than 185 or a diastolic more than 110 is bad to lyse, and therefore you need to aggressively bring the BP down and then lyse the patient. Any head trauma which has an abnormal CT scan, even slight sulcal effacement, you cannot lyse them. It means that already 4 hours have happened. So you need to have a normal CT, you need an acute ischemic stroke to prove that, and you need the right setting. And all the other conditions like major arterial punctures, heparin, anticoagulation, or others would be contraindications. Which patients, this is important, which patients would I extend the lysis even beyond 3 hours up to 4.5 hours? So you can give it to all patients unless in these 4 groups. If the patient is above 80, then don't give him at beyond 3 hours. If the patient has a severe stroke, then don't give him beyond, with an NIHS scoring system of more than 25, don't give him beyond 3 hours. If he's already taken anticoagulants or his INR is high, don't give him beyond 3 hours. If there is a history of diabetes or prior ischemic stroke, this is a second stroke, don't give him beyond 3 hours. So you have set criteria, 3 hours for all deserving candidates, and up to 4.5 hours if none of these is present. What about the blood pressure? There is a little argument about blood pressure. There is increased blood pressure which happens with every acute ischemic stroke, trying to improve cerebral perfusion. But if you allow this BP to be too high, then it will cause problems like cerebral edema and transformation into a hemorrhagic one. We need to have a high BP to restore the penumbra. That's what we saw. But how high is the criteria? And this you all will all be quite surprised, because the levels I'm going to tell you at treating are so different. Acute ischemic stroke will definitely worsen if you drop the blood pressure. And this is a U-shaped curve. I thought my time is up, or it's... Oh, it's just a phone. I thought the time was up. I just finished 10-12 minutes of it. Yeah. So you have a U-shaped curve, and can you see this? That very high or very low BP has detrimental effects. That's not surprising. But remember that an every increase in the systolic blood pressure by 10 will increase mortality by 3 to 4%. But every decrease in the blood pressure by 10 increases mortality by 17 to 18%. So lower the BP, worse the prognosis. So what BP do I target? If this patient is for reperfusion, I do not accept a BP more than 185 or more than 110 diastolic. So how do I bring it down? I can use IV labetalol, I can use IV nicardipine, and the doses are all mentioned. It is easy to have a chart there. I won't go into details. Or you could use hydralazine or enalapril. Do not use other blockers, do not use other drugs. Definitely, please do not use sublingual depin. Sublingual depin, we've got hundreds of cases of sudden death because you've precipitously brought the BP down. Oral depin dena hai to still okay, but that's also uncontrollable. I mean, you do not have a pulse on the problem. The BP may suddenly go down or suddenly stay there. So you need to have only labetalol or nicardipine and in an IV infusion form, and you check the BP every 15 minutes, and if it comes down, you are doing good. If it does not come down after therapy of 3 to 4 hours and you have finished the time window, do not lyse this patient. So BP could be a hindrance for these patients. What about the BP monitoring? You have to monitor BP every 15 minutes for 2 hours. You need to monitor 30 minutes every half an hour for 6 hours, and then every hour for the next entire day. If the blood pressure remains above 180 or above 110 diastolic, then you can give the labetalol and nicardipine still and keep the BP controlled even if you're not lysing. If you have a patient of acute ischemic stroke but who is not a candidate for lysis, look at the BP. You do not treat it till a systolic of 220. You do not treat it till a diastolic of 120. How many of us in the audience allow a BP of 200 by 120 or 110 and don't treat it? We all treat it, right? Which is wrong. It is a wrong practice. It's tough for me also to convince my colleagues that don't do that. If you do that, the chances of worsening the penumbra is more. So we know blood pressure, if you are lysing the patient, you keep it below 180 and below 110, 185 and 110. If you're not lysing, you keep it below 220 and 120, and that's the logic. Besides this, you have causes for older and younger patients differently, like hypercoagulable states, large artery stenosis, cardioembolisms, etc. And our secondary prevention should include treatment like antiplatelets and anticoagulation to prevent a new stroke. I would almost end here by saying that an organized team is necessary for secondary prevention, and I have made a mnemonic of stroke here. S stands for supportive medical care. This is not my poem. S stands for supportive medical care. T stands for treatment of acute stroke, which is lysis or not, rehabilitation, outpatient planning, keep away future strokes with antiplatelets, anticoagulants, and please hunt for a etiological cause. What is important here is, if a patient is specialized, if a patient is transferred to a specialized stroke unit, then there is enough evidence to show that there is a decreased rate of aspiration pneumonia, decubitus ulcer, stroke prevention, stroke recurrence, and even mortality. So this is good. Initially, what should we do as physicians? We should know which patient, what is the blood pressure, how do you prevent secondary damage, which is the patient to lyse, which is the patient not to lyse, and what should be the blood pressure kept for either group. And this is again another mnemonic which I have created. How do you care for an unconscious patient? You obviously look after his airway, you look after his breathing, you look after his circulation, but I have gone on, and I have said D stands for decubitus, this patient needs turning. E stands for eye care, he cannot blink, so you need to tape it or put some drops. F stands for Foley catheter, which all of them need. G stands for a Ryle's tube or a gastric feeding tube, and give them nutrition. H is hospitalize all strokes. I is infection control, IV fluids, and I could go on till this thing, but till Z, but I don't have the time. So are we ready for my poem? This is totally written by me, and I'm quite happy about it. So let's see whether it conveys my entire talk. I'm not here to come as a poet. Don't be hyper and don't take tension. over management of stroke and hypertension. In stroke, the brain will naturally auto-regulate. More importantly, treat pain and ICP as the surrogate. 3 hours or 4.5 hours, we need more data, more study, more trial, to which no one in the audience would probably have any denial. Take only the extremes of blood pressure as an alarm. Remember, always do no harm. In stroke, if the CT scan of the brain is normal, giving the patient fibrinolysis is only formal. If the sophisticated, expensive MRI is unavailable, delaying or denying fibrinolysis is unacceptable and horrible. Carrying out all the Ds from detection till disposition, only then will every stroke victim go home in a great condition. So I thank you all for this. And I just take this 1 minute of opportunity to invite you all for the conference that we are running in November from 6th to 9th in Mumbai. This is the International Conference on Emergency Medicine under the auspices of SEMI, which is Society of Emergency Medicine, and it will be an extravaganza of people attending will be emergency physicians, critical care, and even general physicians. And I would have tracks on localized things and also evidence-based medicine. We'll have tracks for paramedics, general practitioners, and emergency nurses. And this is the lovely venue where I would request you all to come. And this is the website which I would really, really want you all to check on and see whether you all feel that this conference would do good. I thank you all.
Thank you, Dr. Khushrao Bhajan, for an excellent presentation. Any question for Dr. Bhajan? There is.
Dr. Rajan, do you use antiplatelets along with thrombolytics? And
मैं राजेश मिश्रा बोल रहा हूँ
and anticoagulants after you complete the thrombolytic therapy?
Yeah. Sir, the antiplatelets should be held during the time of giving fibrinolysis, but if they've already been given, that's not a contraindication. Generally, when we use TPA, we don't use any other fibrinolytic, like we can use streptokinase, urokinase for MI. We cannot use that for the brain because the chance of bleeding are higher. So we would only use something like TPA. And in that, you always, these are heparin specific. So you need to use heparin along with them. But when you use it for an MI, the same TPA, you need to give heparin simultaneously. But when you have used heparin for, fibrinolysis for a stroke, you need to repeat a CT scan after 24 hours. If there is no bleed, you please start heparin. In fact, you have to use heparin. Heparin should be continued at least for a week. And by that time, if the patient has recovered and mobile, then you don't need to use it.
Any other question?
How do you, no, you don't keep, the patient keeps. Because there is, I couldn't have time to show you the auto-regulation, but what happens in stroke, there is an increase in the intracranial pressure. So what is cerebral perfusion pressure? The blood pressure, mean blood pressure, minus the intracranial pressure. So if your mean blood, ICP has increased, the body increases the mean arterial pressure, trying to maintain the perfusion. So that is called as auto-regulation. So if the ICP is very high, we see patients always hypertensive. So if they are not hypertensive, that's okay. You don't bring the BP up. But if the BP is very high, you do not treat it, because every 10 millimeter drop can increase mortality by 17%. And therefore the criteria, if you are lysing, then 185 and 110. If you are not lysing, then 220 and 120. Sir?
What about regional anticoagulation into the area? Suppose he's a patient, I cannot do anything. He's beyond 4.5 hours.
Yes.
Still there is, either I leave him to become vegetative, or is there any option for a regional anticoagulation?
Very good question, but the focus was on immediate care, on an emergency basis care. But if this patient is crossed the window period and you have facilities in your institute for radiological intervention, definitely please do it, because there is a lot of evidence that it helps. Yes.
And particularly not for serious circulation, we can go up to the
Yeah,
12 or 24 hours, even longer.
yes.
Yes, please.
Chances of ICH is almost double with a tissue plasmin TPA than that of the streptokinase.
No.
Sir, it is mentioned in the
No.
booklet and brochure.
TPA definitely
wrong, you have read, sir.
I would beg to differ. TPA is less bleeding, has less bleeding than streptokinase. Why is TPA so important in STEMI? I'm talking of myocardial infarction, is that the TIMI flow increases double. So with streptokinase, if it increases 30%, with TPA it increases to 54%. Whereas in a stroke, only TPA has been tried. Maybe streptokinase and euro might be used later, but when you start off for a stroke and lysis has come up only 10 years ago. So if you start using every agent, you might have problems.
Sir, in brochure it is mentioned with streptokinase, ICH chances are 0.4% and with TPA it is 0.8%.
Maybe because streptokinase